We can.
All right, SQUAN means Safety and Quality by African Nurses is a non-governmental organization focused on ensuring patient safety and improving the quality of care. We are looking at all healthcare providers, healthcare professionals, allied healthcare providers as well, based or who work in Africa, because over the years, Africa has had an increasing number of, you know, poor healthcare quality. And we are looking to empower healthcare professionals, and nurses are leading this organization. We are looking at helping healthcare professionals do better to maximize or for the patients to, get a better outcome whenever they visit the healthcare facilities, be it the hospitals, institutions, and the home care. So whether rendered at home, in the hospital, anywhere, it should meet the standard. And we're also working towards helping patients get value for their money. We know that healthcare is not cheap. Healthcare is expensive. So whatever they're paying for, they should get value for it. We expect that patients should come out better than they went in. So SQUAN is looking at empowering healthcare professionals via education, teaching, and it's a safe space where you can share your story as well. If you also wish to work with us, partner with us, be you an individual, institution, an organization, you are free to do so. So we have our guest speaker, who is Chika Odiemene, who is first a nurse, and I'll be letting Kubai do the introduction of our speaker.
Hi, greetings, everyone. So my name is Kubai, and I will just go straight to the point. And it's my pleasure to introduce Chika Odiomene, a nurse practitioner and a global voice for healthcare quality and patient safety. With more than 20 years of clinical and system experience across the United States and Africa, she brings a rare blend of bedside insights, operational excellence, and strategic design to the pursuit of safer care. Chika has served as Director of Quality and Patient Safety in a Malcolm Baldrige Award-winning hospital, where she led a joint commission certifications for both disease-specific and non-disease-specific programs and helped reduce preventable harm by over 70%. She is a Malcolm Bridge examiner, a Lean Six Sigma Master Belt, Black Belt, a certified patient safety professional, and an adjunct faculty at Thomas Jefferson's University. She is the founder and CEO of Utopian Healthcare, which houses a certified caregiver training program, an American Heart Association International Training Center, and a home-based care service that uses integrated electronic records to track and improve care quality. Our program has certified over 600 people in BLS, trained more than 1,300 caregivers, and contributed over 500,000 internship service hours. Through outreach across Lagos, Abuja, and Enugu, her team has screened over 4,000 individuals for silent threats like hypertension and non-communicable diseases. She is also the founder of SQUAN, Safety and Quality by African Nurses, a new and upcoming movement to bring nurses to table as co-leaders of quality and safety, and serves as APO chair of the African Community of Practice. Her personal mission is simple and powerful: to be the best wife, mother, daughter, sister, godmother, cousin, and friend she can be, and to be the best patient safety advocate she can be. Please join me in welcoming Chika Odiomene.
Welcome, welcome, welcome.
Thank you so much, Kubai, and thank you, Ijoma, for starting this out right. And thank you, Kubai, for that really lovely introduction. And I want to make a statement also that I am not the only founding member for SMAN. And I don't know who else is here. I know Maureen was trying to join, but Dr. Yeniba, do you mind, when we first started off SMAN, it was a conversation. Everything begins with a thought. And even this first webinar is also one of the conversations that we had. But Dr. Yeniba, I don't know if you can you unmute and say something? If you could turn on your camera, is a plus. But we'd love just a little bit of introduction. And next time we'll have pictures and so that people will know the brain, the design behind SMAN.
Thank you so much, Chika. And it's still very early, quote and unquote, here. So forgive whatever your camera brings to your face. My name is Emmanuel Enigba, and it's a huge pleasure to see something that started as, like Chika said, a simple conversation begin to take form. And this is just early days, but we're very excited to know because we're more than convinced that this is needed. There is a need, and we're designed and well positioned to meet the needs and begin to create the awareness and the movement that is required in the health and healthcare space within Africa and globally. And I would say that we're blessed to have Chika take the lead in birthing and shaping these conversations and this movement. So today's not about the founding members, but I just wanted to say that we're blessed to have you join early, and very soon we'll begin to talk about how you are also properly positioned to drive the conversation and cause the change that you want to see. Thank you so very much, and thanks, Chika, for doing this. Over.
Thank you for for accepting being on the spot. And on behalf of other founding members, we truly welcome you. On behalf of the team as well, Kubai is also one of our founding members who did the introduction. So we are really excited that you're here. And like Dr. Iniba said, the goal is really eventually that you be the one talking about doing this webinar and connecting and growing each other, and we are learning from you. So thank you all for being here. Let's get started. We have lots to cover today. So again, the conversation we wanted to talk about is the topic is why nurses should co-design safer care. And I was careful not to say lead, because nurses will play a critical part in quality and safety, but every member, from the security guard to the person who transports the patient to the person who is doing the operation, the surgeon who's cutting off organs and putting in stuff, we all have a really important part in care. What we've noticed is nurses, especially within our continent, we're not showing up a lot in this space. And this is why we created this space for nurses. And again, we want everyone to join. So very soon you're going to see pharmacists and everyone. But we want nurses to recognize that we are a central and co-designers in this safety journey. So that is why we started to have this conversation. So today, what I want us to do is the objective is first we'll learn basic concepts of patient safety and science. We would also recognize that we will see what's happening in the global space. We want to reflect on our own daily experience. And I will share, so goal of this webinar is to also leave you with a tool that you could go and implement today or tomorrow, like something you could actually use and for safer care in your environment. And also, I want you to leave with something new. If you learn something new today, that will make me happy. And if you don't learn something new, but you learn something that actually validates what you've been thinking silently or in a small group, that is also a plus for us. So before I begin, I'm going to turn this into our mentee. Can you share the link, please, for the mentee? Everybody, take this link, and can you please answer this question? You should, once you take the link in front of you, you can see my screen here, right, with the mentee exam. Can anyone confirm they can see that screen?
Yes, we can see it.
Okay, can you share that link that's with the group again? Okay. Can you guys answer, when you hear of patient safety, what comes to mind? Do you think of formal training in safety science? Have you heard of it but unclear what it means? Or is it a brand new concept? And as you click, everyone can see, nobody can see who answered, but we can certainly see the response we're getting. If you're asked for the code is right on the screen for you. So you guys, what comes to mind? Formal training. Okay. I have 2 responses. If you're struggling with using the link, let us know. Okay. I'll give you a few more seconds. Okay. Excellent. So this makes me happy to hear that we know we have to recognize that safety science is a formal training. It wasn't integrated in our nursing schools. Maybe new schools are doing it now, or schools are doing it now, but it wasn't part of our medical, nursing school, pharmacy school, any of those schools, and it should have been. However, it is an evolving field, but it does demand formal training to understand the science behind the safety. So thank you for taking this, and I'm surprised to hear, and I'm happy to hear that no one says it's a brand new concept. So that's good. That's excellent. So let me also ask you this, nurses here, have you ever felt this way? Oh, sorry, that you have you ever felt? Oh, I'm moving back to. Can you guys see this? Can you see my screen now? I have to go back between the mentee tab, so please remind me. You confirm that you can see my screen now on with the nurse holding everything. Okay, very good. Okay, so why does safety feel heavy, right? We all know that feeling. If you're a nurse, in fact, you don't even have to be. If you just work in a hospital, you know there are so many roles that you play that you even forget the one you studied for, right? You're asked to clean, run to the lab, to explain to families what's going on, and they're not always very happy to be in the hospital. And the kit order on the ward, right? And also, why carrying a whole patient load that maybe 3 people should be taking? So no wonder why safety feels so heavy sometimes, and because we are relying on memory and personal vigilance instead of systems that's designed for safer care. And that is really why we're having this conversation today. So let me tell you a story, a patient story. Mary is a 35-year-old woman who recently underwent a routine cholecystectomy, and post-surgical, she experienced severe pain, fever, and nausea. However, the symptoms were not adequately addressed in an understaffed hospital ward, right? So after surgery, she complained of this pain, and Mary's symptoms were really documented, but initially attributed to, well, you just had surgery, you should have some pain. That's what happens. So as Mary's condition worsened, her symptoms were not immediately escalated to another level of care, but another nurse saw this and said, this needs to be escalated. So by the time they called Dr. Oye, the on-call surgeon, that this was going on, he was able to order some diagnostic tests to confirm if it was a post-operative complication that they were witnessing. But by then, Mary had developed a severe post-operative infection, a bile leak, and despite immediate intervention to address the complication, the hypotension, the fever, all of those things, Mary went into a septic shock, and eventually Mary died, unfortunately, due to the delay in recognition of her symptoms and reacting to it. So if you're thinking what I'm thinking, you're probably asking, so whose fault is it, right? And that's exactly what we do. Was it Nurse Amina's fault for thinking that Mary's skin was normal, or was it the on-call doctor who was told late and who came late? Was it the ward, the unit, for being understaffed and the documentation and escalation slipped through the crack? Because if you're understaffed, that means you're carrying heavier load. And often that's for how we respond to tragedies. We start to look for who to blame. We search for the one person, the one mistake, the point finger. But the truth is, Mary's death was a result of not a one careless nurse or a doctor. It's a result of system that was not designed to catch worsening symptoms in a surgical unit, right? It's a design that did not protect her or protect the staff that were overstretched, and it did not support nurses to actually care safely. So the science of safety teaches us that error are rarely a fault of one individual. Let me repeat that. The science of safety teaches us that errors are rarely a result of one individual. They are actually predictable outcome. If you are in a ward that is understaffed with really complex patients that require really close monitoring, and you're not given that, you can expect death. You can expect complication. You can expect that you're going to lose life. It's very, very much predictable. So sometimes if we have systems that also depend on memory, somebody remembering, heroic act, right? Luck, hope, then we can expect death, we can expect complication, we can expect harm. So we must shift from the systems that blame to systems that are asking, how can we design our flow, our process, so that patients get better care? So let's talk about people versus system, right? A person approach system says, who did this? You're asking, you're looking for who to blame, right? The nurse in charge, the doctor was delayed, you're looking for the staff who missed something. This approach blames and shames, and it assumes perfection is possible if you just try harder. It's your fault. Next time, listen, next time. If that worked, we will have a safer system today. So if anything, that's proven not to work. But the system approach is more asking, he accepts that people are going to be tired, burned out, overworked, interrupted, right? They are working under pressure. Patients are going to get sicker unpredictably. Someone is going to go crazy on the work. You accept that. You accept that this is a condition. So because you know that this is going to happen, you plan for it. So it's designed with checks and redundancies and protection so that even when one step fails, the patient is still safe. So the difference between punishment and progress is if we stop blaming individual, then we start learning. If we do not stop, we will learn and nothing will change. So safety science is focused on design. We can prevent, we expect all these interruptions, and we are designing for better care. So another, let's talk about the Swiss cheese model, right? So the Swiss cheese is sort of what I introduced here, and let's talk about this model. And this model says that there are layers, and I use mosquito net. If you don't know what Swiss cheese is, most of us may know, but it was a model created by James Reason that says that Swiss cheese, the piece of cheese, it has a lot of holes in it, right? And if you take a slice, you cut it, holes everywhere. If you take another slice, with holes in it, it may patch up the other hole. the whole idea is that each slice has a hole, and some holes are bigger and some are smaller. But now imagine lining up those holes. Each layer represents a layer of defense. So if that hole doesn't penetrate through, there's another layer of defense. And that layer of defense could be checklist, equipment policy, alarm, EMR, the communication pattern, right? These are all barriers meant to stop error from reaching the patient and is not dependent on human memory or heroics act. Excuse me. So let's say most of the time the holes, they don't line up. The layers are protecting each other. For example, the doctor writes a prescription, right? And the pharmacy would need to look at that prescription to check it. So in case the doctor just wrote a little dose, the pharmacy has the knowledge and training to say, this is a little dose, let's check. And the doctor will say, oh, I added extra zero, I wasn't supposed to. And the nurse, even before giving the medication, will be more familiar with doses that are common for the patients, because the truth is the doctor is a human being, the pharmacy is a human being, and they can still have mistakes. And we've had this happen. I've had this experience personally in my work journey where a doctor wrote a little dose of medication. Pharmacy happened to be the pharmacist had cancer, had chemotherapy, and somehow came to work because they were short staffed. So she was not mentally with it and completely overlooked the little dose of the medication and prescribed it. So the patient should have been getting 10 milligram, and the doctor wrote 100 milligram because for that just added one more zero by mistake. And the nurse opened up 10 pills of 10 milligram and handed it to the patient, and the patient died. So those layers of holes aligned very well. But the biggest hole was you had a system that was allowed to order a little dose of medication that can kill patients in an instant, stop their heart. So this is a reality that actually takes on. So when you have those layers, they start to help prevent complex issues. Another example I could give about this is mosquito net. So think about mosquito net that's supposed to prevent mosquitoes from biting you. If you have one that, and you know they get holes really quickly. Imagine if you have two, right? So the mosquito penetrates through the first one, but there's another layer to stop it. And that's sort of how we have to look at patient safety in general. There is proof that design works, right? If we really want to understand system design, what it looks like, right? We can look at other higher risk industry. Healthcare is complex, healthcare is high risk, but there are other ones, right? That's shown that when you design with intention, that you can create safety. So let's talk, for example, everybody here, if you're like me, when you get on the plane, we are all saying that prayer, whether it's out loud or silently. We're doing our cross. We do whatever it takes because we're praying for safe landing. But let's talk about in the aviation system. There's one accident per 1.26 million flights. So the chances of you actually crashing with each flight you take in decimals will be 0.000000008 accident per flight. It's equivalent to saying that it's 99.9% safe. Yes, we've had crashes. Yes, without a doubt, right? But for some reason, because it's on the news, there are a lot of people dying, and once it makes it to the news, right, it's highlighted that we all say thank you God for safe journey every time our plane lands safely, every time we take flight, we pray, when all of those things. But healthcare, the chances of you being harmed during an admission is 1 in 4 patients are harmed during an admission. What is the decimal percent of that? 25%. And equivalent to 25, 0.25%, 25%. That's the percentage. I'm sorry. So what does that mean, right? So the difference is not that pilots care more than nurses or doctors or pharmacists. The difference is really design. Aviation treats safety as a science, embedded checks, redundancies, learning into every flight. They have protocol they don't deviate from, that you can't actually deviate from. But in healthcare, we're still relying heavily on vigilance, on people, on memory. And this is why we have to bring science of safety in the nursing practice and in our design system. So let's look at some global reality about unsafe care. Around the world, 1 in 10 patients is harmed while receiving care. That's more than 3 million deaths every year from unsafe care. In our region, in low middle income countries, it's all up to 4 in every 100 patients die as a result of this. These are not statistics. They are people we know. If you think deeply, you can count people into the statistic that you know that you've experienced, family members, friends, neighbors, and whatnot. Harm also is preventable. It's been found that over 50% of this harm you can actually prevent it, and 1 in 20 patient harm is just really unnecessary. Most of it are preventable, and most of it are coming from medication, unsafe medication use. Beyond the hospital, it was found that 4 in 10 patients are harmed in the primary care setting, and up to 80% of those, over 80% of those could be avoided. This is telling us a story that safety should be everywhere. So to put this in a good perspective for you, right? Unsafe care can kill more than HIV, tuberculosis, and malaria in some region, right? So patient safety is not a luxury. It's something that we really need to work through. Let's talk about the economic burden of patient safety. My own is, I may never see this money in my bank account, but if anybody will even give me 0.005% of it, it would be great. So it costs, so global patient harm reduces economic growth by almost 1% per year. And that indirect cost can account for up to trillions of US dollars annually. But what was really important that they found was when you engage patient and family in the design of their care, it reduces this burden, this harm, that by 15%. So there's also that opportunity for us, nurses, physicians, everyone to be included in the co-design, but also recognizing that patients are a central part of that co-design in their care. They're the ones that get to deal with the disease burden and get to make sure that they know how to care for it. According to WHO, the common sources of patient harm are many. Medication error, unsafe surgical procedure, healthcare associated infection, diagnostic errors, patient falls, pressure ulcer, patient misidentification, given Mr. So medication that belongs to the other a person, unsafe blood transfusion, and venous thromboembolism, which is VTE. So there are, I think, about 11. I don't have it all here, but these are some of the most common causes of error. So factors that actually lead to error. We could have blamed Nurse Amina for Mary's story, but when you look at that story, there were system and organizational factors that contributed to that. There were technological factors that contributed to that. Human errors, human factors in behavior, patient-related factors, right? And external factors as well. And what are some of those things? So system, we're looking at complex medical intervention. Cholecystectomy, one could argue that is a pretty straightforward procedure. If you're familiar with it, seen it a lot of times, have a good structure for it. Inadequate processing, resource constraint, inadequate staffing, right? Competency development. The first nurse that ignored it, right, may not have the competency of the frequency of checking patients post-operative and what to look out for, right? So technological factors, issues with EMR, the medication administration, trending. That patient's blood pressure went down low because before you get into septic shock, you're going to show some physiological signs that you're in trouble. Was that picked up? Did we have something that is recording and trending for us to have that visual cue? Human factor and behavior, communication breakdown, ineffective communication. Let's talk about communication breakdown for a second. Every single time somebody yells at somebody or bullies somebody, what will result from that is the next time you need to communicate to that person about any patient issue, you're going to be reluctant to because of what you've experienced in the past. fatigue, burnout, cognitive bias, right? Patient-related factors. Patient did not go to medical school with us. They didn't go to nursing school with us. They didn't go to pharmacy school with us. We cannot be expecting them to know. So we have to be intentional about educating them, recognizing that they will not know. They're not supposed to know. It is the responsibilities on us to meet them where they are. And external factors will include absence of policy, inconsistent regulation, economic and financial pressure. So do we even have policy on how to care for people? Do we have policies to protect us? Do we have any of those? Are we even measuring the care we give? Are we reporting it in a open setting? So when you look at that story, you see how Nurse Amina, who was the closest proximity to the error, is starting to disappear into this list. So, and yet, harm itself is a killer. Unsafe care is a top Unsafe care is a top 10 global cause of disability. 3 million deaths per year. In the low middle income countries, you have about 2.6 million deaths annually, more than HIV, TB, malaria, and all of that. So if somebody asks you to name the top leading causes of death, you're going to call heart attack, stroke, cancer. These things are well documented. Measure that against the death against unsafe care. We have to recognize that safety is not, it must be seen as a priority, not an afterthought, not what we do when things are better. It should be it should be integrated in our thinking already. Like I said, design works. There was a study that looked at using a protocol to reduce central line infection. Remember, central line, a hospital-acquired infection was a leading cause of a contributor to patient harm. So they used a protocol. They actually reduced the central line bond, using the central line bundle bloodstream infection protocol. They reduced CLABSI by 66%. The surgical checklist actually reduced complications from 11% to 7% and death from 1.5% to 0.8%. 0.8% death is a lot for me, because please, whose family will want to be part of that 0.8%? So even when the numbers, statistically, it has a way of just minimizing the human story behind it. Even if it's 0.011%, please, whose family would like to take that position? No one. And that's what we have to recognize, that when we design intentionally, we aim, of course, we get encouraged to reduce harm and reduce death and reduce complication for people, or even the ultimate death. But the goal is really to how do we aim intentionally at zero preventable harm for our patients. Remember the commitment we take that first, we do no harm is the fundamental principle of any healthcare service. No one should be harmed in healthcare. All right. But so what is patient safety? Patient safety is, which is why we're having this conversation, is really a framework that is organized activities that consistently, all the time, consistently and sustainably lower risk, reduce the occurrence of avoidable harm, and make errors less likely, and reduce the impact when they occur. So we're intentional at looking at our culture, our process, our procedures, our behaviors, our technologies, and our environment. I like this WHO definition of patient safety. It is an absence of preventable harm to patients and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. So for you to actually say, okay, absence of preventable harm, you first have to name which ones are preventable. So that means you have to look at which one have we done? Which one should we have prevented? And let me say this without apologies. It's not a blame, it's a hard call out. If you're not measuring the harm that is occurring in your organization, you are harming people. Period. Let me say it again. If we are not measuring the harm that is occurring in our organization, we are harming people. And if you're measuring and you're not using the data to make meaningful changes, you are harming people. So I will not apologize for that. I recognize that sometimes it's not easy to hear, but it's the truth. And until we step into that truth, then we are not going to be ready to move to the next level. So what is the science of safety, this science that we keep talking about? First is there are three things, right? This is the design, making safe way the easiest way, right? So you have to be so intentional about it. What is the easiest and safest way so that human can actually adopt it easily, do it very easily without thinking, you trip right into it, right? Detecting, catching risks before they happen, the near misses, right? There's a lot of focus on when harm happens, we do a root cause analysis, we gather people together, we do all this stuff. We should shift that attention to detection before it actually reaches the patient, because once it gets to the patient, it's too late. And the last one is building layers so that one miss does not become a tragedy. This is not abstract. This is science tested in aviation, in nuclear power, and healthcare itself, as proven by the last slide that I shared with you. So, if science of safety gives us method, culture of safety, gives us environment, a culture of safety is then when staff share values, right? And behaviors that put safety first. Even under pressure, you are prioritizing safety. It's also when it's safe to speak up, right? We know that feeling when you can speak up when something happens. You're saying, "I did it. This is what I experienced." It's not that I did it. This is what I experienced. Because if I experience this, somebody else is likely going to experience the same thing. So let's speak up about it so that we can fix it. Because the person that is ending up with the harm is the patient, right? And when learning is valued over blame, when you speak up, your leader is saying, thank you for telling us this. Thank you because you share this with us, we can make our system and our and I know some of you are going to say that's not what we get. And this is why there's actually a way to measure patient safety. And I share this part too. If you go through ahrq.gov, you can actually get a tool that you can measure how safe is your patient safety culture in your organization. Just taking a poll. But blame culture versus learning culture, what's the difference? In blame culture, we're asking who made the mistake that this leads to fear, silence, and cover up. So if you're in a culture where something happens, you're going to make a mistake. If I ask anyone here, if you ever made a mistake, if you work in the healthcare sector, and if you do not raise your hand, then we will tell you right there you're lying. It's not true. But the better question is not about whether you're going to make it. I've made med errors. I've made mistakes in my clinical practice. I maybe these are even the ones I know. They may even be mistakes that I made that I wasn't even aware that I made a mistake, right? But the better question is when you make the mistake, do you have fear, silence, and do you cover it up? The moment you start to do any of this in the presence of fear, that means that harm is going to repeat itself, is going to scale, and patients are going to continue to be harmed? Or do you also have a learning culture? What went wrong? That needs to redesign, that is encouraged, that people are encouraged so that, because the focus isn't about saying you're a good nurse, you're a bad nurse, you're a good doctor, you're a bad doctor. The focus is saying, oh wait, our design failed me as a nurse. The design failed me as a doctor. The design failed me because when I went to nursing school and spent all those years and money to learn, none of it, I did not plan to harm anybody. I was here to care. So when the design fails me, I think that environment should encourage us to start to say this design is not supporting my intention to care for patients. So here's another clue. When something goes wrong in your workplace, what usually happens? And remember that we're not going to see your responses. So again, can we share the link, if you don't mind? Can we reshare it in case there are people that don't have it? Please go ahead and just put your responses. And it should show on the screen. Anyone?
Chika, I think you need to move the Mentimeter to this current page because it's still showing the previous question that we had.
It's still, oh, I have it.
Yeah.
Now I'm on the next question. Okay, this is the previous one.
Yeah.
Do you see the new one?
No, not yet.
Okay, let me refresh. Let me refresh this
We
one.
need to refresh, yeah.
Do you see the new one?
I'm also refreshing here.
Okay.
No, it's not thinking.
It's thinking?
It's not thinking, it's not in sync. It's still saying when you hear patient safety, what comes to mind?
How about now?
Yes, now. No. Yes, when something goes wrong, yeah, we have it now.
All right. Let's investigate. Investigate and learn. People stay silent. Thank you, investigate and learn. Okay. I like that. I love this. Someone is blamed. Okay. Investigate and learn. Good. Good. All right. Thank you guys for sharing your experiences. That's really good news to hear. Let me click on the next question so that way when I come back there, we are ready to go. Thank you for sharing that. It's good to see that most of us are going to investigate and learn. That's exactly what should happen. So this was me putting the link for the meeting. So let's talk about just culture. Just culture takes it a little further. It balances accountability with learning. It distinguishes between human error and risk behavior or reckless behavior. So if it's human error, because we're human, the only thing that I can guarantee is that you're going to make error. Slips. You're going to be tired one day. You're going to have stuff that on your mind that is not going to keep you focused. We are going to make error. Are we going to make mistakes? Average behavior says, like, making when we deviate, we normalize deviation. What we are really good at as nurses, or even healthcare, we work around processes. If I'm supposed to do this, they train me. This is what you do when this happens, and you get there. The equipments aren't there. You're not. The things you need aren't there. You're going to work around because you need to get by. You have too many patient loads to see. So you immediately start to have at-risk behavior. So we coach about why this is important and bring you back online. But they are reckless behavior. These are people that just intentionally do not care. So what Just Culture does is all about accountability, but learning from the person who was involved in the error. If Nurse Amina was like, I don't care if this patient dies or didn't die, versus Nurse Amina saying, I really didn't know that these things should be escalated. And most people, what do you mean you don't know? Didn't you go to nursing school? And when you start to ask that question, you're blaming, right? But rather to say, okay, you didn't know this. Do you have a protocol? What were you trained? Who trained you when you came on board for surgical complication? What did they tell you? All of those fun things are some of the things that you would learn from Just Culture approach. So it really is about a balanced accountability. Because some people, when they hear Just Culture, they say that you're just letting everybody go through. It's about promoting learning, encouraging open communication, taking a systemic approach. You're looking at the whole thing. So instead of saying, what do you mean you don't know post-op complication signs and symptoms? Didn't you? Which school did you even go to? Who graduated you? You're thinking, okay, what if nurses who come in, new nurses, may not remember everything they've learned? They shouldn't because they're human beings. And these are high-risk patients. How do we make sure that in front of them, they have something that says, this happened, you escalate? How about the last time somebody missed it, we came together and say, hey, it was a great catch. Somebody almost missed this, but because somebody else caught it, we encourage that practice. and you encourage and ensure fair accountability. The moment you start to say, which school did you even graduate from? Who taught you? What kind of nurse are you? These stupid new nurses, all the things we do to eat our young. Guess what? We've left the patient in the discussion. Our ego is now central to this because we are telling somebody that we are better than them, we know better than them. But patient again will become the person that will suffer most for this. So what will a culture of safety do, right? A patient in a hospital will show signs of deterioration, such as increased pain, just like this is the same case. And the healthcare team fails to escalate in a timely manner, leading to the patient condition worsening. What would a culture of safety do? And they will establish and enforce protocol for monitoring, responding signs and symptoms of patient deterioration, such as early warning signs, and empower all staff to initiate rapid response. Even saying, when somebody is going, something, just call. Everybody will gather. Even if it's a false call, let us gather and call it a false call. And you promote interdisciplinary communication. Doctors, when you do surgery, who is the person that will call? If the moment that we're sure that something, who is reachable, right? What would a culture of safety will not do is dismiss, undervalue the frontline staff observation and concerns, lack clear mechanisms for escalating care. How do you escalate care? The last time I called Dr. Oye, he yelled at me. The last time I called this one, they told me I'm not the person. What's wrong with you? Can't you handle this on your own? The last time I spoke to the charge nurse, she told me, please, I don't have time for this rubbish today. So having a clear method of that you are going to escalate any issues, that's what a culture of safety will do, and that's what a culture who will not do is not make clear of escalation mechanism. I hope I haven't confused you, but I think you have my point then. All right, let's talk about workplace. Does your workplace have a culture of safety? So, does your work have a culture of safety? And this is back to mental healing. Do you guys have this? Can you see it? Let me know.
I think there's still a lag.
This is a lag.
Yeah. Can you try to change the slides on the Mentimeter?
Well, let me make it a present.
Yeah, now we have it. Okay. Now we have it.
Given your understanding of what a culture of safety is, does your workplace have it? And by the way, I will not know who is responding, so don't worry, because I have some of my team members here. Yes, consistently, sometimes, rarely. Okay, sometimes, okay. Sometimes, yes, consistently. Okay. It warms my heart to see rarely as the lowest answer, but if that's your reality, please share. Okay. Okay. Thank you. I think I've gotten the trick now to always click this. Thank you for sharing this. So if we really want to keep our patients safe, our culture of safety has to be consistent and all the time, right? It can be sometimes. And if you have sometimes, then you're working on how do we make it all the time? And if you don't have it at all, you're thinking, how do you establish that? Because you're not going to achieve safe care without it. Period. It's that simple. So going back to Amina's case, whose fault was it really? And this is what we wanted to look at the layers of the Swiss cheese. How did everything line up? So remember, there was understaffing in that post-operative unit, and the hospital escalation process is not optimal, was not clear on really how you tell somebody when you're concerned. And culture of prioritizing physician. If you have any doctors in the house, please, I apologize. It's not a blame game, but we do know that there is the culture of saying, whatever the doctors want is sort of what we follow. And when you have that, so if they're not available, don't call them, or I'm not accessible, or inaccessibility sort of that lack of protocol of monitoring post-operative patients. Do we have a protocol? When Amina stepped into that post-operative unit, what was the protocol? How is it accessible? It's not the one you do in the binder and you go and put somewhere and you put in a folder. It's the one that is in front of her every time the patient is in front of her, so that she doesn't rely on memory to remember which blood pressure does she call again, which vital sign, which heart rate should she remember to call. It's one that's in front of her, so she's not using human memory and heroic act. She's falling into a design that is put in front of her to follow. So this is how the Swiss cheese aligned, and that led to patient's death. So when we did a root cause analysis, we asked, okay, why did Mary die? So we said understaffing. Why do we have understaffing? Economic and financial pressure on the healthcare system led to understaffing and insufficient resources in the hospital, right? They're not making a lot of money. They don't have money. They don't have enough staff. They are trying to hire. Their pay is not competitive. So nurses are not coming to that hospital. They're going to other places that pay better. Those are factors. Gaps in hospital policies and procedure for staff training was not there, right? What did you do on onboarding? What did you do continuously? Do you have a continuous learning model? Insufficient emphasis on continuous quality and developing clear clinical guidelines for managing post-operative care. Do you measure the people that you've already taken care of, and how often are you learning their outcome? Are you saying, out of all the patients we've had surgery on, this many had post-surgical complications, this many died, this many they had BPE? Are you measuring this? If you're not measuring, I can guarantee you right now, you are harming people. So why is patient safety so critical? Somebody needs to mute. I'm sorry. Thank you. Why is patient safety so critical? Because it directly impacts the quality of care and patient outcome. In an environment where safety is priority, patients receive the best possible care, recovery time, and faster. And the incident of a hospital-acquired condition is reduced. So it is really important if we are in the service of serving people, right? So the question is, I've shared this. So nurses, you're already in the science of safety. You see the risk first sometimes. You act first sometimes. In this case, who would have been first positioned to see any post-op complication? Would have been the nurse, right? And who should act first? The nurse. And who should have co-designed for, if I see this, what should I do to ensure patient safety? We are already in it, whether you like it or not. So whether you're in this class or not in this webinar, whether you've never heard about patient safety or not, it is already part of your being as a clinician, as a nurse. You're sometimes also the last defense before the harm reaches the patient. You are so if you're not equipped with this formal training, how would you know what to do? So one of the goals of this webinar is to leave you with a tool that you walk away with, change the way you think, apply it today. So the very thing is that you start thinking safety, you notice safety, you start naming it, you start learning from it, teaching it, talking about it, start designing it, and start to understand it. And it starts from this webinar. So the first one I want to teach you is about stakeholder influence and support. Because a lot of you are currently thinking, how would I, a nurse, can you please go and call my leader to come and listen to this webinar? Can you give this, if you're thinking it, can you go and bring all my leaders, all the decision makers to come and listen to this? The truth is, yes, they need to listen to it, and so do you, because the change will not start always with, nobody understands nursing process more than you, nobody understands physician's process more than they do. Nobody understands pharmacy process. And the CEOs are not clinicians a lot of times. Sometimes they are. But you understand this process, but the way in which you communicate what needs to happen matters a great deal. So before you go and say, how do you talk to the stakeholders, right? You need to assess them first. You need to see their support and their influence. You need to say who has high influence on making changes and who is encouraging. Those are your champions. So if your nurse leader, your matrons, they have high influence on changing things and they have your support, then bring them close, right, to the things you're noticing that is making your workflow really difficult. If you have somebody who has low influence but they are supporting, mobilize them. So maybe the person, the administrator on your unit, they don't have a lot of influence in making changes, but they support, they're championing you. Keep them close. The people you need to work on is the high influence people. Maybe they are the people that will make financial decisions, create space for this in the budget, but they are low support. That's the people you need to encourage and persuade into getting, listening to you. And the people without really a lot of influence and a lot of support, just monitor them. Don't. So you need to put people in these four categories when you're looking at your stakeholders for safety. Then when you've analyzed them, right, you have to do three things. When you're talking to a C-suite person, you have to say what concerns them, what impact of the case, what is the impact on the case, and what is the return on investment. Don't go to your CEO and start telling them about how you feel that safety is not prioritized in this hospital, how you feel. Just they're not going to listen. It won't work. And this is why the way we communicate matters. And I felt really compelled to introduce this as part of the first tool that we share. So when you are talking to your presidents, CEOs, chief matrons, all the chiefs, right? They care about reputation, they care about financial stability, they care about legal liabilities. So when you're talking to them, you have to make sure that you're integrating these things that they will listen to into it. And so the incidents may lead to scrutiny. So you're telling them this may lead to public scrutiny of our organization. This may lead to legal issues, right? And we need to start to reassess our staffing policies and procedures. Let's talk about the return on investment. Investing in staff training may reduce risk of costly lawsuits. Something that if we just take this money that we're going to pay in lawsuit and train people, it may actually reduce that. We can now even use this to market to people that this is how safe we are. We are a safer hospital because we are measuring. So you have to also analyze your stakeholders. Another one is if you're talking to a physician on call, right? And you want to get them on board, and they are a part of that. Remember the high influence and high support, or they're resistant. You know that patient outcome, professional reputation, efficiency in care delivery is going to be important to them. So when you talk about maybe surgical stuff, we found a way to make sure that surgeries are not canceled or team are not here and something happens and you have to go home. We have a plan for that. They will lean in, right? Prompt care escalation. We don't want the surgery you've done to go wrong. So we want you to help us educate us on the early recognition, leaning in, bringing them in. So using the things that matter. You're talking to a frontline team. What concerns them the most? Workload, patient safety, job satisfaction, right? So you are saying providing quality care, maintaining safe environments, and having sufficient resources and support is what will be of interest to them. Then if you're talking to your colleague, you're saying, I know you're burnt out, even me. There's something we could do about it. This is the return of investing. Because at some point, if your team members are the resistors, you need to also learn how to persuade them. So when you have your stakeholder influence support metrics, you have the stakeholders aligned and you talk about their influence, and you talk about their support, and then you can now say, these are the people I need to really persuade, and how do I persuade them? You study them, you learn what's important to them, you use the keywords, key times when you communicate with them. So let's pull number 4. Who do you think have let's see, I have to do the present. Who do you think has the biggest influence over patient safety? Ayo, can you see this?
Checking now. Yes.
Okay. Nurse leaders, okay. Yeah. Any more responses? Nurse leaders? Okay. Is understanding for different items per patient and family. I love that. For different items, it may be you have to do the stakeholder analysis. Who has the biggest influence here? And depending on what you're looking at, it may very well be the nurse leader. Some things, if it's financial budget stuff, it may be the hospital administration. For some things, it may be the doctors that will have, but the main idea is that you do know and you're thinking about who has the biggest influence on patient care. So thank you for responding to these questions. So bargaining for safety. When you are bargaining for safety, you want to bring your allies with you, the people that are the supporters, your champions, right? You want to bring safety in a way to protect patients and staff, prioritize them there at the center. I include staff there because there is no patient safety without staff safety. So you have to position it as when you make staff safer or make an environment for staff to function better, that will automatically is a predictable pattern. Patients feel safer. You use evidence, not emotion. It's not that I feel thing, is data. Start to collect some data. So other practical low-cost design action that you could also do. These are some of the tools that I just wanted to share, and they seem random. Start a 5-minute hazard huddle. If equipment is an issue, if it's staffing overload is an issue, every day on your ward, say, guys, let's just talk for 5 minutes. What is the staffing like? Who are the most complex patients? Who is the most experienced patient? Who should we be? Just this conversation alone can actually impact the safety journey in your organization. What do we need to peer double check? What medications are high risk? What are some of the things that who is my partner? Who is my buddy? We used to have a buddy system in one of my nursing experience journey, where you had at the beginning of every shift there was a buddy, and that buddy is somebody that you checked certain things with. So with time, you create this comfort thing where you are allowed not to know, where you're allowed to ask silly questions, if you will, and then start to talk to that. That becomes your buddy for the day. Another thing you could do is a quality and safety information board. Have a board. Listen, if you don't have a board, get paper, pin it on the wall, tape it on the wall, write some safety issue that you're going to focus on today. You could start this today and tomorrow. We don't need till the leaders listen to this. We don't need the policy. We don't need budget. We just start this today. Language that shape our culture. You made an error versus we missed something. It doesn't matter how the proximity you were to that error, right? If you're in that design system, is we. You start to use we. Hey, how did we do this? What do we need to learn from this? You're not going to be able to capture this in number, but statements like this have really large influence on how people think in an environment. So daily huddles are brief, focused meetings where healthcare teams can discuss safety concerns. So this is what that would look like in the soccer game, right? They huddle. They're saying you are the player. You're going to. This is your. I don't play soccer, so I don't really know the position. But this is your position. This is strategy. The other team member, this is the strongest person. Everybody attack him. Make sure he goes down, because if he gets the ball, he's going to score. So the sports people are doing this, and they're just playing ball. And we that are carrying patients' life in our hands, why are we not huddling and talking about the same things? So this is really just to emphasize why huddle are important. And this brings me to the end of the conversation to again, this is fun, and this is what we want to learn. This is a type of webinars, conversations, discussions that we want to do. So we want to encourage you, please join formally, apply, fill out the paperwork. This is going to be co-designed with all of you, with every member. Like we just started this, is new. We don't have any tricks in our pockets. So everything you're learning, we're learning. We may change something tomorrow based on what you what you share with us. we want to know, so the what we currently ideas that we have is we have this professional network that we link with each other, find each other on LinkedIn, find each other wherever we are, connect, promote, comment on the social media, share with your friends. We're going to start to give is free membership right now at launch. We're going to get certificate for this webinar, and with time as we grow, we start to ask for continuing education credit for it, but we're not there yet, but we need the momentum to be able to start to ask for such policy changes. We want to be visible in the global space as and be recognized as a safety movement and collaborate with other safety movements. There are hundreds and thousands of them around the world. And we want to connect with other African nurses working on safety and even encourage those not working on safety to come and join this journey. And it's a platform to influence leadership and policy. As we gain strength, we will be able to do that. So we want to know, okay, what do you need from us? If you've thought of anything, I have this Mentimeter up. Let me go back. Let's see. What do you need as a SPLAN member? Just statements. You could just write these statements as you go. What could you like to learn more about in our webinars? Tell us what you want to learn. Feel free to text it in. And what would help make you feel more supported as a nurse? Feel free to text us. So I'm going to go and review this over time and see if anyone punched in any response. But we really not just want to talk at you, we want to put the down with you, and because we are doing this together, all right? So there is a form out there that says join the movement. Can you please share the form, Ijoma, on the link for application, and also tell us a patient safety story. We want to hear from nurses about patient safety incidents that they're learning from. We want to collect 100 stories. We're not naming countries. We're not naming, it's completely anonymous. So feel confident about that. We even don't ask for which country did it happen, which hospital did it happen. We just want to hear the story from your perspective. So thank you so much. This is an African movement, so I'm hoping that I had everybody see or saying thank you in here. If not, I then fall back to the English one to say, I thank you for being here and listening to this and lending your ears and minds to this.
Good morning, everyone. Okay, so
sorry. This is how you're going to collect your certificate on Nova. Is a 4-minute video. I think we can, I don't know how else to share it, but before we get to this, let me stop and take questions, comments. Thank you.
Please ask your questions, or you can drop them in the chat box. But before the questions, thank you very much, Chika, for your lecture. There were some points you raised that caught my attention. Where you talked about having safety as a default button. It shouldn't be something you need to think twice. Whenever you're caring for a patient, be it in the hospital, care home, anywhere, it should be your default button that not these patients, nothing should happen to this patient. This patient shouldn't go worse than he or she came. And also, we also raised the point of, having layers of protection so that before the actual harm happens, this thing must have been detected, this thing must have been prevented. And he also talked about us avoiding blame game. Healthcare practitioners, be it the doctors, the nurses, the pharmacists, and some other persons, blaming, it's not me, it's the nurse, it's the doctor, it's the pharmacist. Let us come together and learn from it and find the solution to that problem so that it doesn't reoccur. Because it becomes more problems when these things begin to reoccur. Instead of solving one problem, you now have multiple problems. It can bring litigations. It can also affect the identity of the hospital and the individuals involved. I so much loved those points that you raised. Thank you so much for this lecture.
Thank you so much for that summary, and you're spot on. If we blame, then we're just not going to learn. Period. There's no learning there. So absolutely, thank you.
Please ask your questions.
And feel free to unmute and ask as well if that helps. Raise your hand and you can. It's okay if you don't have questions. If you need to just digest all the information load that you just received, that's also understandable as well.
Can I just come in? Another point you raised is when you said the data where you have 0.8% of the population affected by poor safety, and it may look small to some people, but it's very big, because when that patient is not related to you, that patient is not your friend, you may not understand the level of hurt or the level of damage done. But if that person is your family member, if that person is someone you know, put yourself in that person's shoe, and that's where empathy comes in. Because you don't know that person, it's just a patient, it's just a stranger. I think the percentage is just small. But when you put yourself in that person's shoe, what if this person was my child, my mom? Nobody wants to fall into the 0.8% category. Nobody. And that is why we should work very hard to, prevent it at all. It should be at 0%, 0.00%.
Exactly. I know statistics, I think they have strength. They tell us progress, how we're doing. But sometimes we confuse that we've arrived. We've not arrived. If it's like you said, if it's 0.0, that's a somebody's story behind that. Thank you.
Okay, I have a question here. Someone is asking, how do you promote safety when nobody is held accountable?
So accountability is an interesting concept, and I think when you promote safety, is a lot of times it's through a leadership journey. It's a leadership that has, just like we mandate this, and this. Leadership it starts with leadership, and they have to walk the walk, talk the talk, and that creates that accountability system, right? And that is why if your leaders are not really leaning into this safety journey, they may not know. We have to appreciate them. They may not know, because just like none of us we learned this in school, right? It doesn't stop us from being leaders. It doesn't stop us from being so acknowledge that they just do not know. So how do you also, this is why I talked about the stakeholder analysis. How do you start to introduce the concepts to them and using keywords and key terms in a way, because it truly starts with leadership. Once leaders say, okay, this is a direction we're going to take for our organization, which every healthcare organization should be taking a direction. There are all these pillars. We talk about finance pillar, we talk about customer pillar in any strategic plan of any organization. We talk about, everyone knows the finance. Safety and quality should absolutely be part of it. So that's what I would do. If your leaders aren't involved, you start with the analysis and find ways to start to talk to them, because you are in this webinar listening to this. They're not. And most of us did not learn this in school. Thank you for a great question.
Thank you very much for shedding light on that question. Odera, I hope she answered your question. Do we have any more questions?
Am I still sharing my screen?
Yes.
Okay. So I want to talk about how do you get the certificate. There's another question, please. In an institution where other healthcare team members aren't helping in cleaning up, how do you go about it? Teamwork is an absolute design of leadership and understanding how important it is. There were programs designed. There's a Team Step program out there. Team Step, look it up. Like Team and Step. I think the words are together. Team Steps. But when leaders start to embark on this leadership journey, on this safety journey, they start to recognize how influential teamwork is, and they start to design for it. Right now, in the absence of intentional design for teamwork, team building, nothing happens. Everybody's just showing up with their wahala or trouble or whatever it is they're coming into work with and just displacing it on each other. And there's the bickering. But once leaders understand that teamwork, teaming up is important, they essentially start to design a system that promotes team building. They are talking about it, they're encouraging it, they're actually and a lot of times, I think leaders feel like, okay, I need to do the heavy lifting. Everybody wants teamwork. Nobody wants to be in this bickering mood. No, it just doesn't feel good. But most people don't really know how to go about doing it. If the intentions are there, you'll find so many programs and templates that are really easy to apply into team building. Is another intentional design. People are not just going to show up and function well together. It just is never going to happen. You have to intentionally design it. So thank you for that really great question. So for your certificate.
Good morning, everyone.
We've
okay, so I'll be taking us through how you can go through your course.
Are you guys hearing that?
Also download your certificate. So
are you guys hearing
it is expected that you've registered for Nova as a student already. And once you've logged in, just come through your dashboard. Then
yes, we can.
In here, you go to courses, click on my purchase. So my purchase is the amount of courses that you've actually enrolled on already, and go through your course that you actually like to work on.
I had to stop it because
choosing a particular one.
It's not aligned.
And this is foundation of patient safety and quality science. I click on it and I scroll down and go to the learning page. On getting to my learning page,
I'm not sure why this is still playing.
I'll click on this, and patient safety, I want to see the live class or the recording on that aspect. And once I've gone through the live class or the recording, I'll turn on my toggle button to say that, okay, it has actually been done. Then please, I will encourage us to refresh or reload our page. And refreshing of the page, you see that it's going to increase your learning progression. Then once you are done with this, then the next one is you want to answer the quiz assigned to this particular course.
Are you guys hearing
so this? Please, when you want to do your quiz, you have to attend to it systematically. You have to do section 1, 2, 3, 4,
yes,
5,
we
like
can.
that. Do but section 1 and jump to section 3. It's going to
no,
give
we
you
can't see it.
Denied. No, so you click on section 1, you click on the quiz itself. Once you click on the quiz, it takes you to the quiz. Please answer the questions before you click on finish, before you enter particular quiz. Then once that is done, you go to the next one. Like I said earlier on, you want to jump to section 3, then you want to click on that particular.
So sorry, I had to stop that from playing. I wanted to share my screen, but I believe that we've sent in the ways to get how to get your certificate. We did put in some questions that you can answer. You have 2 chances of getting them. There are 10 questions. You get 80, you get your certificate. It's just a way of saying, making sure that you've actually listened to the webinar and getting your certificate. Share your certificate with us. Let us know that you were successful at it. Any other question? We have 7 minutes to go. Any comments? Congratulations, everyone, on finishing our first webinar. More of this to come. More and more of this to come, and more speakers. And on behalf of the founding members and also our team members, people working behind the scenes to make this happen, thank you for this. We have some learning to do, obviously, but we really thank you. And if you have any feedback for us, please share. I hope you learned something new and useful to you. Thank you all. And back to you, Ijeoma. Ijeoma Kubaya, are you there? I'm handing it back.
All right. Thank you very much, Chika, for a very productive meeting. We have learned a lot, and in the absence of any other thing, I would just say, so we've sent out how to download your certificates. If you're finding difficulties, please reach out, so we can put you through. Please, we would love to hear feedback from you about how today went. We would also love to get suggestions on how, if you feel we could do better, how we can make this better next time. And the journey is just beginning, and we have a lot to learn. And welcome everybody on board. Registrations, membership registration is still ongoing. Please endeavor to become a member of SCOAN. Let's together as nurses, let's make Africa, nurses part of African healthcare, championing patient safety. Thank you, everyone. And in the absence of any other thing, I will say bye for now. Do have a great afternoon.